Okay, this is part 2 of the neurological assessment. I'm going to be focusing on mental status in particular. And there's several aspects of mental status, so we'll go through these. Again, this is shareable. You can download the PowerPoint at SlideShare, I think it's called. I've got a link on Paramedicine.com. So go to Paramedicine.com and you'll be able to download the slides there if you want to use them. So when we talk about mental status, what are some of the things that we're talking about? It's kind of tough to define what it means to be, alert and aware and awake and present. It's a vague sort of term. So we'll talk about alertness a little bit. And the definition that we have of alertness is a description of how well somebody responds to changes in their environment. So when things happen around people, do they pay attention? We've all, familiar with the term, spaced out or something like that. And if someone's sitting there kind of, my family would call it dwamming. If they're just sitting there sort of dwamming and you go, hey, Mark. What? You think, well, something's wrong with your ability to respond to your environment there. We may not say it that way, but we might say something like, dude, where'd you go? It's abnormal. We recognize that. So usually people are alert. And the way we'll describe alertness is by using this formatted statement. The patient is responding to this stimulus by this reaction. So patients responding to verbal with normal speech. Patients responding to pain by moaning. Patient is unresponsive to pain. One of the most immediate sort of first tests of alertness that we do is called tracking. So when you walk into the room as a paramedic, people are usually freaked out because it's called a paramedic is a bit of an extreme situation in their life. And then we show up and we're wearing our flashy uniform with reflective striping. Usually there's a bunch of people who come through the door at the same time. If it's just you and your partner, that's a bit odd for people to have. We've got the machine that goes ping in all our bags and everything, and people are going, whoa. So if you walk into the room and somebody looks at you, and then as you walk towards them, they look at you, oh, hi, how are you? Then they're tracking you. They're following you with their eyes, and that's good. If you walk into the room with your flashy clothing and all your equipment and everything, and the person just sits there kind of, and you go, hello, sir, my name's Mark, I'm a paramedic, how are you? You think, uh-oh, this is not an alert patient. They're not responding normally to verbal. They're not tracking me as I walk in. So that's our quick sort of intuitive test. Are they tracking? And when I teach students, usually in scenarios and stuff, they've just fallen into the habit of saying, is the patient tracking me as I enter? Yes or no. Very good, quick clinical clue. So normally, in order to give us a gradation of how alert somebody is or is not, we use something called the Pugh Scale, which you're probably familiar with, but let's just go over it quickly. So in my report to the foreboding physician, I said the patient is alert and oriented to person, place, and time with memory of distant, recent, incident, no amnesic gaps. So what do I mean by alert? Well, we can say they're responding normally, and that's our short form for alert. Or they're responding to verbal. So if I walk in and they're not really tracking, or if they've got their eyes closed on the bed, maybe they're just resting, maybe they're dead, maybe it's somewhere in between. And I say, hello, ma'am, can you open your eyes for me? Ma'am, can you open your eyes? My name's Mark, I'm a paramedic. Can you open your eyes for me? Oh. Then they're responding to verbal. Now, sometimes we have to lean down and go right beside their ears and say, open your eyes, please. And if they respond to that when we're kind of yelling in their ear, then we specify that and say that the patient is responding to loud verbal, not normal verbal. So either they're responding to verbal or they're responding to loud verbal. If they're not responding to verbal, so they're not tracking us, we say, hello, can you open your eyes? Hello, can you open your eyes? And they don't respond to either us coming in or the loud verbal, then we're going to actually inflict a little bit of pain, very judiciously, very carefully, very compassionately. And we're going to see how they respond to that pain. And the Glasgow Coma scale has a set of scores for how well somebody responds to pain, specifically how they move when we inflict some therapeutic diagnostic pain. And we'll talk a little bit about that. But is the patient responding to pain? This is getting progressively more ominous as we go, right? Or maybe the patient is unresponsive. So let's look at that pain. The pain that I recommend that you use is to press down on the patient's nail bed here, just at the bottom of the nail there, that little white semicircle. If you have a pen and you put it on their nail and squeeze the pen, oof, that really hurts. Now, there's a small subset of people that this doesn't hurt at all. But the people it does hurt, it hurts a lot. And it doesn't cause a lot of damage. So it's very difficult to sort of pretend that you're unconscious when someone's squeezing on your nail if you're sensitive to that sort of pain. And I say when you do that, take the patient's arm and move it away from their midline so their arm is extended straight out in the perpendicular to their body, and do the squeeze there. Why do we do that? Well, first of all, most importantly, safety first, you're far away from the patient. So if they go, hey, and they take a swing at you, you've got a chance to get away. Second of all, it's less damaging to the tissue. Other painful stimuli that I'll see people use are very often midline stimuli, and I'll talk about why that's not such a good idea. So, rubbing the sternum or doing a trap squeeze or squeezing on the ear, which does nothing to me. Unless you took a pair of vice grips, you just can't hurt me. I've had students squeeze as hard as they can, and it just doesn't do anything. So if you've got a little old lady or a little old guy, especially somebody on steroids, and you start, rubbing their skin, you can really hurt their skin. It's a lot harder to hurt someone's finger just by squeezing their nail. And because it's not a midline stimulus, we get a much clearer differentiation of what it is that they're doing. So if I've got their painful stimulus away from the midline and they do this, that's clearly withdrawing. If they do this, that's localizing. If they start to do this, that's decorticate. If they start to do that, that's your decerebrate posturing. But if you rub somebody like this and they go like this, is that decorticate? Is that localizing? It's difficult to tell. So doing the painful stimulus as far away as possible from the midline is the most diagnostic. The other thing, and in this day and age, it's always important, but in this day and age, it's particularly important with social media, is that if you walk into a little old lady who's, say, lying on the sidewalk and everybody's got their cell phones out and you go, ma'am, could you open your eyes? Ma'am, hello. And then you take your knuckles and you start rubbing along her sternum and they go, oh, that looks terrible. That's very disturbing for people. And, it gives a bad impression of our profession. There's clinical rationale for why we would do that, but we need to be sensitive to appearance as well. So taking someone's hand, moving it away from the midline, squeezing them a little bit, it just looks like you're holding their hand. Nobody goes, ooh, what are you doing? They just go, oh, what a nice paramedic. Look, he's holding your hand, and you're going, oh, and squeezing on their finger. You're applying pain, but it doesn't look bad. And that's important, especially if it's a concerned family member. You're walking in and it looks like you're damaging, you're injuring this person that they've called you to help, not hurt. So that's why I strongly recommend this. There's another thing about it. So you can see, this is me lying on the ground. Gee, I'm wearing the same clothes. It's me lying on the ground, and my colleague Scott, he's off to the side and he's administering pain by putting his pen on my nail bed and squeezing. Now, we should have done this a little bit better. If you want to do this properly, Scott should really be on the balls of his feet, ready to jump back. If he's on his knees, he's a little bit trapped. If I come over swinging, he can't get away as fast. So modify this a little bit, and when you're doing it, make sure you stay on the balls of your feet. So what we showed there is good. What we're showing here is bad. Here's Scott trapped on his knees, looming over my head, causing pain. So what's going to happen? I might just wake up and see this guy looming in my visual field, hurting me a lot. That's what woke me up. And what am I going to do? I'm going to come out swinging. And if you do that, you're trapped. Now, here's a fun thing you can do in class when you're studying, or, continuing medical education, whatever you want. If anybody ever approaches you like this and plants their knees down beside your ears and starts doing a pretend sternal rub, just grab them. Just like giver. Just go at them, grab them, roll them over, and then just pretend to be, pounding them away. Don't really hit them. But there's such adrenaline that comes out of that, and there's such a fear factor that comes out of that. I do this with my students sometimes in class when I see them planting on their knees, and I say, try that with me. Let's see how that goes. And I'll usually pick like the biggest guy, just so that, they don't get hurt and nobody's offended by me, beating up on someone small. And I'll roll them. And once I do that, you see the entire tone of the class change. Whereas people were coming up before and going, hey, let me just wake you up. And they start doing sternal rubs. They're like, they start approaching the patient like this, ready to fly away immediately. which is exactly what we want. So you can dice it up a little bit in your classes or your learning situation. If somebody's planting their knees and presenting their arm right over for you to grab, then grab it and roll them over and pretend to beat them up. And people will go, I'm not doing that again. And you'll inculcate this sense of safety into people, which is really critically important. No exaggeration, it can save a life, a paramedic's life. So always be on your feet, ready to fly away when you're causing pain to somebody. That's why we don't do this. Okay, so that's alertness. Now, orientation. Orientation is a part of that little speech that I gave to my foreboding physician, oriented to person, place, and time. And this is really quite simple. So do they know their name? Do they know who they are? Are they oriented to place? Do they know where they are? If you've never worked with a patient before, you're probably going to be very surprised the first time when you ask a patient, you're sitting in the back of the ambulance, traveling en route to the hospital, and you say, can you tell me where you are? And they go, yeah, I'm in my bedroom. And you go, what? And you look around, you're in the ambulance, and you go, tell me again where you think you are? I'm in my bedroom. And say, take a look again. Can you realize that you're actually in the back of an ambulance? Look, there's a window. There's a car behind us. And they get confused. So until you actually ask the question, you won't necessarily discover that people don't know where they are. And it's often surprising when they demonstrate that they don't. So ask the question, what's your name? Where are we now? And I usually do this last one in a specific way. I say, without looking at your watch, can you tell me roughly what time of the day it is? And most people should know the time of day. Now, a lot of people will say, what day of the week is it? Or what day of the month is it? I often don't know that, and I'm relatively oriented. And if you ask my dad, well, my dad has dementia now, but if you ask my dad before, when he was retired, he'd have no idea what month it is. So ask him roughly what time of the day it is without looking at their watch. Because as soon as you say, can you tell me what time it is? People go, sure, it's 1:30. So, it's not what I want. So preface it with, without looking at your watch, can you tell me roughly what time of the day it is? I just want to know if you know. And that's how we can ask if they're oriented to time. So we'll often abbreviate this in many systems as oriented times 3. So if you hear other people saying that, or if you start saying that and people know what you're talking about, then you can make this a bit shorter and say they're alert oriented times 3. If you say oriented times 3 and everybody goes, what does that mean? Then you can't use that short form. Find out what other people say. But usually there's some sort of short form for their orientation. Okay, next we're going to ask about memory. So I said patient has memory of distant, recent, and incident, which is pretty self-explanatory. So distant memory, we can ask the patient something like, where were you born? What city were you born in? What hospital were you born in? If we're asking about recent memory, if it's, at night, you can ask them about something that happened during that day. It's 10 o'clock at night. What'd you have for dinner? If it's 7 o'clock in the morning, what time did you go to bed last night? We can ask things like that. Or what time did you wake up if they're actually out of bed? Or what'd you have for breakfast if they've already eaten? And then we can ask specifically what happened to them that made them want to call the ambulance. And of course, we're trying to get the answer to that question to figure out what's wrong. But when we're listening to the answer, we're also listening to see if they know what actually happened to them, if they have a memory of what happened to them. Sometimes we'll show up and talk to people and say, so what happened? And they go, I don't know, man. I don't know. And we think, ooh, they've got a gap in their memory here. So we're trying to figure out whether they've got distant, recent, and incident memory. We want to know all of those. In a lot of systems I've worked in, if you said the patient has memory times 3, they would not know what you're talking about because that's not a common short form. So sometimes you'll have to say they've got distant, recent, and incident memory, because we tend not to have a short form for that. But if your system does, then use it. Speak the local language, right? The other thing we want to know about memory, the second thing is, are there any amnesic gaps? So amnesia, we all know the story of people who have amnesia. They can't remember who they are or where they've been or how they grew up or their name or anything like that. Amnesia doesn't necessarily have to be global. Sometimes we have very brief periods of amnesia in our memory track that we can't access. So let's draw a little bit of a timeline, and on the, x equals 0 is a while ago, and x equals the end of the line is now. in there, something happened to them. So perhaps they woke up this morning, they went to work, they sat at their desk, they thought, I'm going to get some coffee. Asked people what coffee they wanted, walked down out of the building, started to walk across the street, they got hit by a car. That's the incident. After they got hit by the car, traffic stopped, people came over, said, are you okay? They moved them over to the side of the road, called for paramedics. We arrived, they sat there, they heard woo, 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 woo. As we get closer, we get out of the ambulance, we've got all our kit. We walk up and we say, hi, my name's Mark, I'm a paramedic, how are you doing today? And now, it's now. So there's a bit of period before the incident, and if they have amnesic gaps before the incident, let's say you show up and say, can you tell me a bit about what happened? They said, yeah, I got out of bed and then went to work, and the next thing I remember, I'm sitting on the side of the road. Like, how'd you get to the side of the road? Well, I kind of remember, I think I was going to get coffee, and then I was talking to people about coffee, and now I'm here. Well, that's retrograde amnesia. They don't remember. And we might say things like, do you remember the sound of the siren as it approached? Or do you remember me walking in? And if they say yes, then they don't have anterograde amnesia. But it could be the other way around. They could tell you the story. I got up, I went to work, got everybody's coffee, was going across the street, I saw a car, and I turned to it, and next thing I know, you guys are here. Okay, do you remember moving from the road to the side? No. Do you remember who helped you? No. Do you remember hearing the sirens as we approached? No. Do you remember us pulling up at the ambulance? No. But do you remember getting hit by the car? Yeah, look, I could see the person was really scared, and I was thinking, oh, I'm sorry, I didn't mean to step in front of the car. Like, I remember that. Okay, you remember everything leading up to the incident, but then after the incident, you've got a gap. That's an anterograde amnesic gap. So it's helpful, it's useful to differentiate whether it's retrograde amnesia or anterograde amnesia. And the way I remember this is that retro music is from a while ago. So, you know, the 1980s has retro music. That was from before the incident now. So we'll call that retro. All right. Any gaps? Anywhere in there, are there any gaps? So we've got the Glasgow Coma Scale, and it's a standard tool. It's used a lot, but it's not a very good one. If you go to Life in the Fast Lane, great website. They have a lot of details about what's wrong with the Glasgow Coma Scale. So here's the thing I tell students. You have to know it, you have to use it, but don't give it a lot of credibility in your own mind clinically. It's a useful common tongue, but it isn't really terribly diagnostic. So this is the GCS. I'm assuming you know what it is. I'm assuming you're used to testing it. If you're not, then get used to it, because this is just a basic tool you've got to know. But there are some problems with it, and I'll go through these kind of quickly. First of all, we'll say people have a GCS of like 8 or 13, and we add up all the numbers together. It was never meant to be used that way, and it's non-specific. Well, it's not specific in general, but it's even less specific when we use it that way. So if you're reporting a Glasgow Coma Scale, you should be reporting it. Their GCS is eyes 4, verbal 5, motor 6. We should always report it that way. Don't add that up and say GCS 15, because 15 is okay, but that doesn't really help in non-top scores. So if you were to say, for example, patient has a GCS of 4, and the components of that added score are 1, 1, and 2 for the eyes, verbal, and motor, you've got a mortality rate on average of 48% in somebody with a score of 1, 1, and 2. On the other hand, if they have a GCS of 4, same GCS total, with the components of 2, 1, and 1, there's a predicted mortality rate of 19%. Big difference, right? A half versus a fifth, roughly. So if you want to use the GCS with precision, report it with precision, okay? Don't ever use the total score. Or if you do use the total score because doctors or nurses say, stop telling me all the subcomponents, tell me what the actual score is, because that's what I have to write down. Then you say they got a GCS of 4, which is a 2, 1, and a 1. Make sure you're giving the different components. Brainstem reflexes are a really important indicator of how well someone's brain is working, and that's the whole idea of the neurological assessment. Well, the GCS doesn't incorporate those, so it's missing a big view of the person's brain and how it's functioning. If they have unilateral pathologies with their motor score, so for example, if their right side of the face, right arm isn't working very well, the GCS doesn't pick it up, because to use the GCS properly, you give the best score that the patient is capable of. So if you say, can you wave your fingers? And they go, well, I'll go wave these fingers, that's okay. Then we give them full motor scores because that's their best score. So the unilateral motor pathology is hidden in the GCS. Of course, as a good clinician, you'd report it anyway, but it would be better if we had a tool that automatically incorporated it. For younger kids, it's not very good. When we change from the pediatric GCS to the adult GCS, there's this overlap of area where it's very difficult to use. And the GCS is not meant for individual patients. Now, there are a whole bunch of clinical rules that you'll hear. GCS 8 means you intubate. Ridiculous. You don't do that, because the GCS was never meant to be applied to one patient in general. The intent of the GCS was to describe a population. So people with a GCS of this score, on average, not that specific patient, but on average, tend to have this sort of a mortality or morbidity rate. So people will try to use this as a very granular, narrow focus tool. It's not. It's not at all. It's a bit helpful for a trend over time in a patient, but as we'll see, we can't actually take a GCS very well, even if you're a neurologist. So I question how useful that is. So there's a lot of problems performing the GCS. It's meant for traumatic brain injury as a repeated tool in neurosurgical wards to try and get a trend with an individual patient. And as we said, epidemiologically, give us an idea of how well people with a certain score do in terms of recovery. If you're an untrained staff, it's very difficult to use. Even neurosurgeons get the GCS wrong 50% of the time. And when you've got a highly selected population like neurosurgeons, who are very, very clever women and men who have trained diligently and are actually really good at what they do, if they're getting this tool wrong 50% of the time, that's a problem with the tool. That's not a problem with the operator. So that's another problem with the GCS. Verbal scoring is difficult. If English is their second language, if they're intubated and they can't speak, I've heard lots of different rules. I've heard that you put a null if the patient is intubated. I've heard that you put a T if they're intubated on your charting. There's no real standardized approach to this. As we said, subject to language barriers. We can't use this with small children. That overlap, there's the pediatric GCS, the adult GCS, and then that overlap in the middle where it doesn't work very well. It was originally designed to test for traumatic brain injury, as we said. But what if you're drunk? What if you're stoned? What if you're hypoglycemic? Then the GCS is going to give a false score, because anyone with a decreased GCS, we tend to assume they've got traumatic brain injury, but they might not. So GCS is non-specific that way. Also in toxicology, it's non-specific, but it tends to be used specifically. And there's a lot of debates about when we should be doing the first GCS. And for example, when is the first post-resuscitation GCS to be taken? Do you do it as soon as somebody gets a heartbeat back? Well, they're probably not going to have any awareness as soon as they get ROSC, return of spontaneous circulation, ROSC. They're probably not going to get any sort of neurological awareness right away, because they got a whole bunch of toxic metabolites that have developed during the hypoxia, and they've got to metabolize those out. So at what point do you use it first? I can't tell you. I don't think anybody knows. So it's not a very specific or useful tool. We've also said there's a lot of problems with the accuracy. Poor inter-observer reliability. I line up, 5 really experienced paramedics, like the best paramedics in your service, and we put them into a scenario with a mannequin that is reproduced exactly the same every time, and you're going to get like 6 different scores, or at least a variety of different scores, because there's very poor inter-rater reliability. And reproducibility is poor. If I do a scenario with those really good paramedics, and then the next day give them the exact same scenario, they're going to come up with different scores than they were using, that they gave you the previous day, because it's just really difficult to get an accurate, consistent GCS. There's very little evidence that demonstrates that it's valid or reliable. Unstructured clinical judgment seems to be just about as good. And there's lots of other scoring systems that we can use. We tend to use AVPU, and quite frankly, if you're using AVPU and including a good motor score, including unilateral pathology, you're doing just as well as the GCS, if not better. We've said GCS 8 means to intubate. It's a poor technician who relies on a rule like that. It's a much more sophisticated and nuanced decision about when to take advanced airway control over a patient than just what their additive score is. So I'm going to really recommend that you go to Life in the Fast Lane, and also if you go to ScanCrit. They've got some good criticisms of the Glasgow Coma scale that even if you're using it, you should be aware of. You should know the quality of the tool that you're using and when you can and can't rely on it. My whole point in this is to make you wary of relying on the GCS. And if I have accomplished my mission. Yes, use it. Don't trust it a lot. If you got any questions, leave them in the comments and I'll get back to you. Thanks very much.